Picture this scenario. You are a healthcare professional in the middle of a really busy, chaotic shift.
Always the case, right?
Always. And your next patient presents with an acutely swollen, red-hot, and exquisitely tender knee. I mean, they can barely tolerate the weight of a bed sheet resting over the joint.
Oh, yeah, the classic textbook presentation.
Exactly. It's the classic acute, single swollen joint. And the immediate reflexive suspicion that pops into your head just based on sheer prevalence is usually gout.
Right. But right behind that thought,
Shadowing it like a dark cloud is the immediate and truly terrifying alternative.
septic arthritis.
Septic arthritis.
And that differential diagnosis is really the crux of acute rheumatology and emergency medicine, because you're dealing with two wildly different trajectories.
One is a highly painful but ultimately manageable metabolic condition.
And the other is an absolute joint-destroying medical emergency.
Yeah.
I mean, a bacterial infection in that closed synovial space can rapidly degrade the articular cartilage, sometimes within a matter of days.
And easily seed the bloodstream, threatening the patient's life with systemic sepsis.
Exactly.
So that brings us to the core clinical dilemma we're unpacking today. We are looking specifically at patients who actually have a very low likelihood of gout based on their history or their presentation.
Which happens more often than people think.
It does. And in those low probability scenarios, when exactly should you perform a joint aspiration? How do you balance the critical, unyielding need for an accurate diagnosis against the discomfort, the practical ward logistics, and the inherent risks of introducing a needle into a potentially sterile joint?
It's tough because joint aspiration, or arthrocentesis, is drilled into us as the standard clinical instinct. We are trained from day one to want the fluid.
Right, get the fluid.
Always get the fluid. But the physical procedure is only half the battle. The true nuanced challenge you face in clinical practice lies in interpreting those fluid results when the clinical picture is murky. You know, when the patient just doesn't fit neatly into a diagnostic box?
We should probably unpack this default posture first. The natural instinct, the golden rule you learn early on in your medical training, is to perform joint aspiration with synovial fluid analysis in all cases of acute monoarticular arthritis whenever gout is even remotely suspected.
Yes.
You prep the skin, you use the sterile technique, you draw the fluid, and you send it to the lab.
And the rationale for that default posture is anchored entirely in diagnostic confidence. Synovial fluid analysis gives you a tremendous objective advantage.
Because the specificity of the test is unparalleled. Right?
Unparalleled. When you send that fluid down to pathology and they evaluate it under polarized light microscopy, they're looking for something very specific.
The crystals.
Right. If they identify classic needle-shaped, negatively birefringent monosodium urate crystals, your diagnostic uncertainty basically drops to zero. You have clinched the diagnosis of gout.
You know exactly what you are dealing with, which means you are actively preventing inappropriate, unnecessary, and potentially harmful treatments.
Exactly. You are not admitting them for IV antibiotics they don't need.
And you're not missing a crucial opportunity to start the right targeted anti-inflammatory or initiate urate-lowering therapy down the line. But we know there is a much heavier reason we tap the joint. It's never just about finding the urate crystals.
No, it's not. The most critical function of that joint aspiration is the ultimate rule-out. It serves the mandatory role of excluding septic arthritis.
Because septic arthritis must never be missed.
Never. Even if your clinical gestalt leans heavily toward a gout flare tapping the joint to ensure there was no bacterial infection, brewing is the absolute cornerstone of patient safety. You are looking for a gram stain and ultimately the culture results.
So for you listening, standing there at the bedside, weighing your diagnostic options, leaning toward aspiration is generally the safest initial strategy. It balances diagnostic accuracy with patient safety. You get the fluid, you look for the crystals to confirm gout, and you culture it to rule out a catastrophic infection.
It feels like a very clean, straightforward algorithm.
It does, but the reality of clinical medicine is rarely that clean. We run into a major complication when your clinical intuition, supported by the patient's history, tells you this patient probably does not have gout in the first place.
And this brings us to the low probability paradox.
Yeah.
This is the scenario where the patient simply lacks the classic risk factors.
Right. They don't have a history of podagra, that classic first MTP joint involvement.
They aren't on thiazide diuretics or calcineurin inhibitors.
They don't consume high purine diets, and maybe their serum uric acid has historically been completely normal. your pretest probability for gout is incredibly low.
But adhering strictly to that golden rule we just
Yeah.
discussed, you decide to aspirate anyway, primarily to definitively rule out infection.
Right. The fluid goes to the lab, the cultures are pending, but the microscopic report comes back quickly. No monosodium urate crystals seen. A negative result.
And the crucial insight here, and this is a cognitive trap many seasoned clinicians fall into, is what that negative result actually means for the specific patient. In these low probability patients, a negative joint aspiration does not reliably exclude gout.
Let's make sure we are highlighting the mechanics of this because it feels counterintuitive.
It really does.
You performed the invasive diagnostic test. You specifically looked for the pathological marker, the crystals. They were not there. And yet, we cannot safely document gout excluded in the chart.
No, you can't. We have to look at the pathophysiology of an acute flare. In early or atypical presentations of gout, or in joints that are not the classic big toe, the actual crystal burden suspended in the synovial fluid might be incredibly low.
During an acute inflammatory phase, the dynamics of the joint space are chaotic.
Highly chaotic. Crystals can be deeply embedded in the synovial membrane or shielded within microtophi on the articular cartilage rather than floating freely in the aspirated fluid.
Furthermore, the massive influx of fibrin cellular debris and inflammatory cells can physically obscure the few crystals that are present.
Exactly. Sometimes the concentration is simply so low that even a highly skilled microscopist won't capture a crystal in the specific aliquot of fluid they place on the slide.
This has a massive clinical application for the practitioner on the floor. Relying purely on a negative aspiration in a low pretest probability scenario can be highly misleading.
Highly.
If you take that negative microscopic result at face value, completely cross gout off your differential diagnosis, and start hunting for zebras, you might end up anchoring on the wrong diagnosis entirely.
You might doom the patient to recurrent unmanaged flares and progressive joint destruction simply because you trusted a false negative.
This is exactly where rote procedure, just following the algorithm blindly, must give way to nuanced clinical judgment and adjunctive evaluation. A negative tap in a low probability patient is not a free pass. It is a proceed with extreme caution sign.
Absolutely. Now, the framework we just discussed relies heavily on having some degree of diagnostic time and clinical equipoise. There are, however, specific patient factors that dramatically alter this entire decision-making tree.
Situations where the clinical scales are tipped so heavily that your actions must pivot immediately.
Right. The primary exception to any nuanced deliberation is when there is a high clinical suspicion of septic arthritis.
We have to identify who these high-risk patients are. We are talking about the immunocompromised populations.
Patients on biologic therapies for rheumatoid arthritis or inflammatory bowel disease.
Patients undergoing active chemotherapy or those on chronic high-dose corticosteroids. In these individuals, the classic systemic inflammatory response is often severely blunted.
They might not mount a fever. The joint might not be screamingly red. But the risk of a silent destructive bacterial infection is astronomically high.
We also look at patients who are showing profound systemic signs of illness. Rigors, a sudden unexplained hemodynamic shift, or altered mental status accompanying a swollen joint.
In those high-risk categories, the rule is unambiguous. Urgent aspiration must be performed to secure the culture. But more importantly, empirical broad-spectrum antibiotic treatment must be started immediately.
You never delay antimicrobial therapy in these patients while waiting for the fluid analysis or the gram stain to come back.
Never. Delaying treatment in a high-risk patient with suspected septic arthritis is one of the most significant clinical errors one can make.
Because the cartilage destruction in bacterial arthritis is mediated by proteolytic enzymes released by both the bacteria and the patient's own neutrophils, this degradation happens rapidly, measured in hours and days, and it is irreversible.
You draw the fluid, you send it, and you start the empirical coverage. You can always de-escalate the antibiotics later if the cultures remain sterile at 48 or 72 hours and you eventually find urate crystals, but you cannot regrow destroyed articular cartilage if you waited too long to pull the trigger on treatment.
That covers the do not wait scenario. But we frequently encounter the opposite logistical problem on the wards. What do you do when gout is highly likely the patient has a classic presentation, a known history of urate crystal deposition, a classic dietary trigger like a heavy seafood meal and alcohol, but a joint aspiration is strictly contraindicated?
This is a very real, very practical dilemma. Let's say there is a raging cellulitis directly overlying the joint space.
If you pass a needle through that infected skin, You risk tracking superficial bacteria straight into a sterile joint capsule, iatrogenically causing the very septic arthritis you are trying to avoid.
Or consider the patient who is on therapeutic anticoagulation, perhaps a novel oral anticoagulant for atrial fibrillation.
The risk of inducing a massive pressure-inducing hemarthrosis by tapping the joint is unacceptably high.
Exactly. When aspiration is contraindicated but you strongly suspect gout, making a clinical diagnosis is perfectly acceptable. You can initiate targeted treatment for the acute flare, whether that is colchicine NSAIDs or systemic corticosteroids, based on the clinical picture alone.
However, this approach carries a critical caveat. You must employ careful, rigorous clinical monitoring.
That rigorous monitoring is essential because you don't have that definitive synovial fluid analysis acting as your safety net. You are flying blind to a certain extent, relying entirely on the patient's phenotypic response to the medication.
And that lack of a safety net means you must track their trajectory closely.
Very closely. If the patient does not respond to the empiric gout treatment as rapidly and robustly as you would expect, usually within 24 to 48 hours, or if their systemic clinical status begins to deteriorate, that persistent clinical uncertainty demands a comprehensive reevaluation.
If the uncertainty persists, an aspiration should be planned the moment the contraindication is resolved or can be safely medically managed, such as briefly reversing the anticoagulation if the clinical picture dictates it.
Absolutely.
Now, before we dive into the really complex, ambiguous cases, we need to briefly fence off what is entirely out of scope for this specific decision framework.
That's a great point.
If you are evaluating a patient presenting with polyarticular arthritis, meaning multiple hot swollen joints simultaneously, or if they present with severe, profound systemic illness and multi-organ involvement that falls entirely outside of the acute monoarticular algorithm we are discussing today.
Polyarticular presentations open up a completely different, vastly more complex differential diagnosis.
The clinical thought process shifts toward rheumatoid arthritis, flares, reactive arthritis, disseminated gonococcal infection, or severe systemic autoimmune processes like lupus.
The localized rules for an acute single swollen joint simply do not apply there, and those patients require much broader serological workups, blood cultures, and entirely different management protocols.
Let's bring our focus back to the single swollen joint and re-enter the diagnostic gray zone. You have a patient, their pretest probability of gout is low, but you went ahead and tapped the joint primarily to rule out an infection.
Yeah.
The fluid analysis comes back negative for crystals, and the gram stain is negative for bacteria. But your clinical suspicion that something isn't right, that this might still be an atypical gout flare lingers. What are the immediate next steps after a negative tap in this ambiguous scenario? You cannot just document the negative result and discharge the patient without a plan.
No, you absolutely cannot. When faced with a negative tap but persistent clinical suspicion, you have to lean heavily on adjunctive diagnostic strategies. First and foremost, look to adjunctive imaging.
Musculoskeletal ultrasound has become an incredibly powerful tool in rheumatology for this exact reason, hasn't it?
It really has. You can visualize the articular cartilage and look for the classic double contour sign. This is a hyperachoic enhancement over the surface of the hyaline cartilage, which is highly indicative of continuous urate deposition, even if the aspirated fluid itself didn't yield freely floating crystals.
So ultrasound can bridge the diagnostic gap when the fluid lets you down. And beyond ultrasound, advanced imaging like dual energy CT scans can actually color code chemical compositions, identifying hidden urate deposits in challenging deep joints or the spine where aspiration might be anatomically nearly impossible.
That's right. But beyond imaging, we have to talk about the physical realities of the fluid sample itself. Poor sample quality is a massive, often overlooked confounder.
The logistics of the draw matter immensely. If you performed a dry tap and only managed to extract a few microscopic drops of fluid from the needle hub, or if the fluid was heavily contaminated with peripheral blood from a traumatic tap, the pathology laboratory's ability to identify crystals drops significantly.
Blood cells physically obscure the polarized light. Furthermore, you must consider who is looking through the lens.
This is a critical point regarding expert microscopy. Identifying crystals under polarized light is not a simple binary task. It requires significant practice and specialized skill.
It does. Urate crystals are negatively birefringent and needle-shaped, meaning they appear yellow when aligned parallel to the axis of the compensator. Calcium pyrophosphate crystals, the culprit in pseudogout, are positively birefringent and rhomboid, appearing blue under the same alignment.
If the technician or physician looking through the microscope isn't highly experienced, it is dangerously easy to miss sparse crystals, misidentify their birefringence, or misinterpret artifact like corticosteroid remnants from prior joint injection, or even dust on the slide as a true pathogenic crystal.
Uncertain crystal identification or a high suspicion clinical picture with a negative result from a non-specialized lab mandates an expert rheumatological review, or if feasible, a repeat tap when the effusion reaccumulates. At the very least, you must ensure extremely close clinical follow-up to track the natural history of the flare.
Let's organize these pitfalls. These are the common cognitive biases and diagnostic traps that physicians frequently fall into on the ward when navigating these ambiguous joint presentations. First trap, relying solely on a clinical diagnosis without attempting an aspiration in ambiguous atypical cases.
We established earlier that clinical diagnosis is acceptable when aspiration is contraindicated. But if there's no contraindication and the presentation is in classic podagra, relying just on your clinical gestalt risks serious misdiagnosis.
You might confidently treat for gout with high-dose steroids suppressing the local immune response of an early septic joint leading to catastrophic consequences. The synovial fluid is your objective anchor when the clinical picture is adrift.
The second major diagnostic trap, which bears repeating due to its prevalence, is assuming a negative fluid analysis definitively means no gout. Absence of evidence is not evidence of absence, especially in those low pretest probability patients or early in the disease course. You must integrate the negative finding with the entire clinical continuum.
Which brings us to a massive, physiologically fascinating trap. Using synovial fluid cell counts or inflammatory markers alone to diagnose gout or distinguish it from infection. There is a profound overlap in the inflammatory response between these two conditions.
Yes, when monosodium urate crystals precipitate in the joint space, they don't just act as passive irritants. They're actively phagocytosed by macrophages, which triggers the activation of the NLRP3 inflammasome inside the cell.
That intracellular activation triggers a massive explosive release of interleukin-1 beta. The resulting cascade causes profound neutrophil chemotaxis.
And the influx of white blood cells is so aggressive that the synovial fluid can quickly become opaque and look almost exactly like purulent bacterial pus.
Because of that aggressive immune cascade, an acute gout flare can easily generate a synovial fluid white blood cell count of 50,000, 80,000, or even over 100,000 cells per cubic millimeter with a massive neutrophil predominance.
That is the exact same laboratory range, the exact same cellular profile that you see in a fulminant bacterial septic arthritis. The cell count merely tells you the joint is incredibly angry. It absolutely does not tell you why it is angry.
If you just look at a white count of 60,000 on the lab report and think that is far too high for a metabolic flare, it must be an infection, you will be completely off base. You cannot interpret synovial fluid results in a vacuum.
A high cell count in a patient with a classic podagra presentation and a known history of tophaceous gout means something entirely different diagnostically than a high cell count in an immunocompromised patient with a new undifferentiated knee effusion and a low-grade fever.
Which leads right into the adjacent trap, relying on unvalidated numeric thresholds for synovial fluid parameters. We love neat binary numbers in medicine. We want a cutoff where we can say less than 50,000 means gout and greater than 50,000 means infection. But human biology doesn't cooperate with our desire for simplicity. There is no magic white blood cell cutoff. You have to look at the whole picture, integrating the cell count with the crystal analysis, the gram stain, and the patient's specific risk factors.
And the final trap is one we touched upon earlier. Over-relying on non-expert microscopy without stringent quality control. You must know the capabilities of your specific laboratory.
If you are practicing in a setting where the fluid is being evaluated by a generalist without specific high-volume experience in synovial fluid analysis, you have to interpret a negative crystal report with a healthy dose of skepticism, particularly if the clinical features scream microcrystalline disease.
We have covered a vast amount of ground today on a surprisingly nuanced clinical issue that presents itself constantly in emergency departments and primary care clinics. If you had to distill this entire diagnostic framework into one overarching clinical summary to carry on rounds today, what is the core rule? The core rule is this. Perform joint aspiration with synovial fluid analysis to confirm a diagnosis of gout, and most importantly, to definitively exclude septic arthritis whenever clinical uncertainty exists. It remains the most powerful objective tool we have for that initial patient triage. However, You must never exclude gout solely based on a negative aspiration in cases where the pretest probability was low.
In those ambiguous, frustrating scenarios, you cannot rely on the test alone.
Right. You must integrate adjunctive evaluation, like ultrasound, recognize the limitations of sample quality, ensure close follow-up, and ultimately rely on your own seasoned clinical judgment.
It is a delicate balance of trusting the procedure for what it can tell you, but maintaining a rigorous, healthy skepticism of a negative result when the clinical picture doesn't align. Which brings me to a final provocative thought to leave you with as you head back into the clinic or onto the wards.
Let's hear it.
We've established clinically and physiologically that a negative fluid analysis doesn't reliably rule out gout, especially in these low probability atypical cases. Given that reality, you have to wonder how often might subtle, atypical presentations of gout be masquerading as entirely different joint pathologies in our clinics? How many patients are out there right now being written off as having stubborn early osteoarthritis flares, mysterious localized tendinopathies, or unexplained structural pain simply because their very first fluid draw came back clear and the clinical team stopped looking